Text 1. Endometriosis. Endometriosis is an estrogen-dependent inflammatory disease that affects 5 to 10% of women of reproductive age in the United States. Its defining feature is the presence of endometrium-like tissue in sites outside the uterine cavity, primarily on the pelvic peritoneum and ovaries. The main clinical features are chronic pelvic pain and infertility. Endometriosis can be the result of diverse anatomical or biochemical aberrations of uterine functions. For example, endometriosis commonly develops in young women with vaginal obstruction of outflow, possibly because of large quantities of backwashed menstrual tissue that has become implanted on pelvic organs. In contrast, endometriosis can also involve mechanisms that are independent of anatomical abnormalities. For example, the incidence of endometriosis is increased in women who were exposed in utero to environmental toxins or potent estrogens. As cellular and molecular mechanisms involved in endometriosis are being uncovered, the disease is developing from a local disorder to a complex, chronic systemic disease. Endometriosis can be inherited in a polygenic manner. Its incidence in relatives of affected women is up to 7 times the incidence in women without such a family history. There is evidence of linkage to chromosomes 7 and 10, but no relevant genes in these regions appear to have yet been identified. The 3 clinically distinct forms of endometriosis are endometriotic implants on the surface of the pelvic peritoneum and ovaries, peritoneal endometriosis. Ovarian cysts lined by endometrioid mucosa, endometriomas, and a complex solid mass comprised of endometriotic tissue blended with adipose and fibromuscular tissue. Residing between the rectum and the vagina, retrovaginal endometriotic nodule. All 3 types may be variants of the same pathologic process, or they can be caused by different mechanisms. Their common histologic features are the presence of endometrial stromal or epithelial cells, chronic bleeding, and signs of inflammation. These lesions can occur singly or in combination and are associated with an increased risk of infertility or chronic pelvic pain. The inflammation involved in endometriosis can stimulate nerve endings in the pelvis and thereby cause pain, impair the function of uterine tubes, decrease receptivity of the endometrium, and hinder the development of the oocyte and embryo. Endometriosis can also cause infertility by physically blocking the fallopian tubes. The treatment of infertility caused by endometriosis is surgical removal of endometriotic tissue or assisted reproductive technology. Whereas the usual treatment of pain is a combination of medical suppression of ovulation and surgery. Peritoneal implants are resected or vaporized by means of an electric current or laser. Ovarian endometriomas and rectovaginal endometriotic nodules, however, can be removed effectively only with the use of full dissection. Epidemiologic and laboratory data suggest a link between ovarian endometriosis and distinct types of ovarian cancer. Clinical evidence clearly points to a deleterious effect of uninterrupted ovulatory cycles on the development and persistence of endometriosis. First, symptoms of endometriosis usually appear after menarche and vanish after menopause. Occasionally, a rectovaginal nodule remains symptomatic in a postmenopausal woman, suggesting that its persistence is independent of ovarian estrogen secretion. Second, multiparity is associated with a decreased risk of endometriosis. Third, the disruption of ovulation by analogues of gonadotropin-releasing hormone, GnRH, oral contraceptives, or progestins reduces pelvic disease and the associated pain. In line with these clinical observations are the findings that indicate major roles of the ovarian steroids estrogen and progesterone in the development of endometriosis. In humans and other primates, estrogen stimulates the growth of endometriotic tissue, whereas aromatase inhibitors that block estrogen formation are beneficial, as are antiprogestin. In patients with endometriosis, levels of nuclear receptors for estrogen and progesterone are strikingly perturbed in endometriotic tissue as compared with normal endometrium. Finally, biologically significant quantities of progesterone and estrogen are produced locally in endometriotic tissue, through an abnormally active steroidogenic cascade that includes aromatase. Serdar E. Bulan. Endometriosis. New English Journal of Medicine, January 15, 2009, pp. 268, 269.